and their clinical significance and interpret the function reports. It's not that easy. It's simply not that easy. That you have to interpret the function reports. Means you have to know in detail. Otherwise, interpretation is not that easy. That you will realize in a short while. What is the problem? And the way the subjects are taught and answers are, questions are made in the question paper at your level. I am really concerned because you don't have that much clinical exposure. It requires time. Anyway, I will cover. Endocrinology has been covered in physiology. Any part of endocrinology? No? So you know a little bit about thyroid during your class 12. So just to tell you, it is briefly, it is located in front of the neck, and if you look very carefully, you will be able to recognize whether the gland is enlarged or not. Normally, it is not visible. So as I told you yesterday and day before yesterday, that in reality, the ongoing tests, real-time tests are not done in epilepsy, and the same is true for thyroid function test. We are measuring the levels of thyroid hormones and trying to have an assessment of how the thyroid gland is functioning in a given individual at a given point of time. See, the thyroid hormone levels also varies. There is a diurnal variation, and when the patient will come, the patient is in disease conditions, and the disease will fluctuate. The levels will not be same. What is today the level, and maybe after 1 week, it will not be same. Okay. So real-time testing, that is, as you all know, that thyroid gland takes up iodine to produce thyroid hormone, and whether the gland is taking up the thyroid or not, that is done by radioactive iodine test, and that is done by nuclear medicine department and not by biochemistry. There is a specialized unit. These isotopes are allowed to be ingested, and a scanner is there, and thyroid scanning is done. I'll discuss in a short while. Actually, post-MD, after observing for 5 years several reports of nearly 10,000, I thought it's a good point to have to take a research work, and I have done a PhD on it, covering 4 topics. Let me tell you, there is an organ-specific book. When I was doing my PhD, I attempted to purchase this book. This book was costing at that time 15,000 rupees. It was equivalent to my 2 months' salary. And this volume was available right now, even yesterday, I got it from Amazon site. It is costing 14,000 rupees. And this book I purchased, the Southeast Asian edition. Since this book was beyond my capacity, I had to get at least 400 pages photocopied from this book, and I had to read for my PhD. So latest edition book, you can see that is costing 20,000 rupees. See this, I am showing this thing because it is not possible to digest all these things by any given individual even a thyroid specialist, I am telling you, and so it cannot be covered in 1 hour time. During my study also, there is a special book on inherited disorders of thyroid system. This, I got a PDF copy and got it printed and read it simply. Actually, during my professional service life, the most gold standard method for thyroid immunoassay, radioimmunoassay is basically thyroid estimation assay is radioimmunoassay. And we used to do thyroid estimation at our hospital using reagents from Bhabha Atomic Research Center, Mumbai. And the TSH kits used to be brought from Canada and repacked at Bhabha Atomic Research Center, and it was brought by air to Durgapur. So after I I had tried to analyze what the doctor's perception is that the T3, T4, TSH, which is commonly done, they try to match it. Now, my point, whether after analyzing 10,000 data, what is there, you can see whether that correlation can at all be made. The answer, simple answer is in a given individual case, its answer is no. You may get, but most of the situations you will not get the matching between T3, T4 or among T3, T4 and TSH. So, as I told you, since I had done a research work and my paper was published, 5 publications, so I can at length tell about thyroid, and please ask some questions today or next time which I will not be able to answer. I will be happy. I will be happy because I have to then go into the depth. So, as you can see, this paper was published from Durgapur to Berlin and New York in 2002, and you can see this book. The Thyroid World Authority and Robert D. Utiger was the author. Somehow my paper drew attention of Dr. Robert D. Utiger, and he was kind enough, that is the American Thyroid Association publication, and my paper was abstracted, and he was the editor-in-chief of that journal, and he made a summary of what my paper is and wrote a commentary. So, this was a commentary how my research work, it's a basic research work, is clinically useful for the doctors. That was the basic purpose of my doing the research. So, all 5 papers are related to clinical fields only. But that paper, since it was published internationally, it drew attention. I wish during your professional life, you will also not be posted all persons in good hospitals, but in resource poor setting, observe. And yesterday, 5 students were there in colorimetry class, BS law. They have seen with a small instrument of 1,000 rupees how a class, world class research can be done also. So that these persons have seen. So from a small hospital, I have been getting some article archived in USA. It is a matter of great pride for me. So basically thyroid function test will be covering. So without knowing the synthesis and regulation, it will be difficult. So I will be telling you very brief, a bird's eye view of what the synthesis is and what the regulation of secretion, and then I will go to at the end thyroid function test. This is one case. Her mother was suffering from thyroid disease. There is a goiter, and soon after the baby was born, this is a girl child. I made a real attempt not to allow this. She was supposed to have a goiter, and you can see the image here. It was when she was a 4-year-old baby. I mean, a child. There was no enlargement, but subsequently, thyroid gland started enlarging. Just look at this thing. If you want to examine thyroid, allow some water to be drunk. The moment she is drinking, I mean deglutating, you can see the visible thyroid here. Now you see, she was a little bit aged, and now you look at the thyroid. Now, again, she was aged about 7 years when this photograph was taken, and I was really worried that not only she will suffer from psychological stress, but her marriage will be a big problem. So I took it up as a challenge and treat the baby and also her mother, and yesterday night I told her husband to send the photograph of that baby and fortunately you can see now if you look at that baby now, this child, that girl child, she is now 14 years old and the swelling has completely disappeared. And her mother was having a big problem, big thyroid swelling also. Now if you look at the front part of the neck, you see this is almost, can you see any swelling? There is no swelling. You look at this thing. Both the mother and her daughter both are happy because they don't find the swelling. The dose adjustment is very critical. Diagnosis is very critical, and that is the reason why I am showing you the live description of what I have done. So I wish all of you will also be very much diligent in handling patients, treating, selecting the appropriate doses, and you must be able to interpret the first report, and then only you will do that thing. So note down these 5, at least these points before I talk high things. All these may not be required. Write down. Something I will ask you to note down. These are the things which you must know, the basic baseline information. So thyroid gland, which hormone it produces? That simple answer doesn't come out. So these are at least remember these things. So thyroid gland produces 2 hormones. One is T4 and one is T3. 100% of T4 is produced by the thyroid gland. Remember, but only 20% of T3 is produced by the thyroid gland. Rest 80% of the T3 is obtained from peripheral conversion of T4 to T3. Remember, 100% T3 is not produced by thyroid. In contrast, T4 is produced absolutely. There is no other organ which produces thyroid. Okay? Since triiodothyronine, this thyroxine is having a 4 iodine molecule, so it is formed by one molecule of this T3 is produced by one molecule of diiodotyrosine and one molecule of monoiodotyrosine. And T4, it is having 4 iodine atoms, it is produced by 2 molecules of diiodotyrosine. This is a minimum information you must have as a student. And it is produced from the iodination of tyrosine residue of thyroglobulin molecule present within the thyroid colloid. I will discuss. I will explain. Write down, there is one protein called thyroglobulin. That thyroglobulin protein is having a tyrosine residue. That tyrosine residue is iodinated. And from where this T4 hormone is produced, and T3. So they, after production and release from the thyroid gland, they are carried through the bloodstream to different organs. So through a carrier protein, just like bilirubin. Bilirubin, yesterday you know that, knew that it is transported by albumin. So apart from albumin, there are other carrier proteins called thyroxine binding globulin, thyroxine binding pre-albumin and albumin also. So these I will tell. So both T3 and T4 are present both in bound form and free form. Write down. T3 and T4 are present in both bound form and free form, and the free form is very negligible percentage. You can see the free form of T3 is only 0.3%, that means 99.7% is bound form, and that acts as a store. And similarly 0.03% of total T4 is in free form, and that is the active form, and that controls its own secretion, that exerts its activity. So rest is within the reserve in the blood or in the gland. Okay, so we are having an extensive storage capacity. So diseases occur when the storage capacities are exhausted. That you must remember. So the free form are biologically active. T3 is more active than T4. Actually, in our body system, T3 exerts its action. From T4, T3 is produced and that T3 exerts activity. So therefore, since it is producing T3 and T4 hormones and it exists in total form and free form, so ideally if you do this 5 hormone test, third functions, you will get a functional status. If all the levels are normal, TSH is the controlling agent of T3, T4, production by the thyroid gland. So write down these 5 points at least. So if you do T3, T4, TSH, FT3 and FT4, you will get a complete idea about the functional status of thyroid in a given individual. T3, T4, TSH if you do, you will not be able to get a little idea why I will tell you. Since as I told you the free form is active, you must know the percentage of the free form. If it is within the normal limit, then you must be sure that there will not be a great disturbance of the metabolic functions. That is the importance of having a free form. During our time, free, free, ekdom, thank you very much. Ratre kore type korechi onekta. Yes, it will be pre-triiodothyroidism. Write down please. I am sorry. I am sorry. Please point out mistakes if you note. And this will be free thyroxine. Why this F word is written? To indicate free. Total there is no prefixing. T4 means it is total. F T4 means it is free. T4 and the levels are different. So some relevant information, only whatever I have written in the underlined red, that you note down. Daily requirement of iodine. It is 150 microgram. There is a range between 100 to 150. The latest book of community medicine recommends 150. So 90% of the iodine comes from food and rest from drinking water. Iodine deficiency is geochemical in nature, means iodine is present within the salt, within the earth of a given geographical area. So from that area we get a drinking water, so that water contains iodine. Vegetables are grown on that earth, so we get iodine from the vegetables. Even the animals also graze on those fields and they get iodine from those vegetables. So basically from rest of 10% iodine we get from the foods. Whatever we take, normally there was no iodine deficiency until there is a geochemical deficiency. And these areas, West Bengal area, are not geochemically deficient in iodine. 80% of the total iodine thyroid is stored in the thyroid gland, iodine. Earlier, protein-bound iodine was given, it was tested. So there are several great Calcutta expert endocrinologists who used to ask the patient not to take iodized salt, but to take the salt which is being sold during our time when we were MBBS students, sack salt, where there is no iodination. And there is an artificial crisis of iodine deficiency, and then they used to evaluate and used to do some wrong things. See, Government of India, there was a water control program in 1962, and in 1982, Government of India took a landmark decision to iodize salt, and to all the commercially available iodines are available from 1992, and today you will not get non-iodized salt until unless you specifically ask for. So iodine deficiency will not occur from the diet. The goiter which we are seeing today is not a iodine deficient goiter. That must be clear. Earlier it was there. Because of the iodination of salt, it is not there. So this was a landmark decision government of India for it. So even if you take iodine adequate, there is a problem. The iodine cannot be utilized by the body, because since I was in Durgapur for a long time, I knew that the industrial effluent water are simply discharged into the Damodar river, and that is the source of drinking water for all the steel plants and industrial belt downstream Damodar river, and that used to be contaminated, and that chemicals used to be present in that food, in the water, that water we used to drink, and using that water vegetables were grown, cattle used to graze on that field. So through the food chain, those chemicals used to enter our system, and they used to interfere iodine absorption or iodine utilization in the body. So these are called goitrogens. There are many food items which contain, but the amount of these goitrogens is not sufficient to cause goiter. So since there is no awareness, I had to write one article on environmental goitrogens, and I had to present it at an Indian Medical Association conference, and I had to make an awareness program that the goiter which you are seeing may be due to environmental goitrogens, not due to iodine deficiency. And in fact, I tried to do a study on effects of environmental pollutants and thyroid gland for 2 long years at local RE college, which is now NIT Durgapur, but failed. Because West Bengal Pollution Control Board did not allow to publish the data. I am telling you in public right now. Why? Because if that water is found to be contaminated with those goitrogens, there will be big public outcry, and there will be public unrest. So just to prevent that, the West Bengal Control Board don't do the research work and don't publish the data. They told me confidentially after 2 long years. So if you want to do that thing, any good research work, that is also prevented, just like tobacco. We know tobacco causes cancer, we know tobacco causes diseases, but no government is coming forward to stop production of tobacco because it is giving good amount of taxes, earning revenues. It's a big problem. If you want to, medical person don't want to do research work, I attempted, but every time I attempted, there is some obstructions, somewhere or other. So these are, I mean, just not written in the book. Sometime in your professional life, you will face this type of difficulties. That's why I told it. I attempted. Thyroid hormone synthesis, I will give a brief overview. There are 11 different steps. You read it from the book. If you are interested, I will tell you only the salient points which are required for thyroid function test. So it's not that easy, not a simple procedure. So thyroid glands it is located in front of the neck, as you have seen from the video itself. So these, if you dissect it, just like hepatic lobule, its weight normally is 25 grams, but it varies from individual to individual, because you know the size of an individual is quite variable. Somebody is having 4 feet 10 inches, 5 inches, 5 feet 5 inches, 6 feet, like that. So their thyroid gland weight will also be different, and the body weight also. So if you look at this thing, there is a colloid, and within this colloid, that thyroglobulin protein is there, and iodination takes place there, and just like hepatocytes, thyrocytes are there, and they are metabolically active organs, metabolically active cells, and they produce thyroid hormones. And this is a complicated procedure. This cannot be covered in this class. Just first point is uptake of iodine from blood and concentration of the thyroid gland. We are taking iodine in the diet or through the salt. That iodine is being absorbed by the intestine and it is taken up by the thyroid gland against a strong electrochemical gradient. And you can see the thyroid serum thyroid ratio of iodine is 25:1. So thyroid is accumulating 25 times more than what the serum is there. So there is an active pump is required. Without that pump, you cannot allow the iodine to be entered into the thyrocytes. So this step is stimulated by TSH and this is inhibited again by thiocyanate and perchlorate. Unfortunately, if you have an anti-TSH receptor antibody, so that despite having a TSH receptor, that thyroid TSH will not act on that thyrocytes and you will have an artificial crisis. So if you see that this is the structure of the TSH, this is coming and on the cell surface it is interacting, there is a receptor. This is the receptor and TSH is coming and it is giving signal and that basically allows the iodine to be taken up. And now if you have a TSH receptor antagonist, like here the antagonist, now that receptor is blocked. So thyroid is coming, TSH is available in the blood, but it is not allowing it to function. Also, if you have an antibody developed against its own this TSH receptor, again this TSH receptor will not be able, despite having an TSH available in the circulation. So that will not allow. So TSH receptor antibody, antagonist or TSH receptor antibody will not allow the TSH receptor to function. Interestingly, this anti-TSH TARB, it can be blocking type and it can be stimulating type. If it blocks, that means it will not allow the thyroid gland to produce function properly and it will cause hypofunction of the gland. That will lead to hypothyroidism. And if it stimulates, it will allow it to overfunction. So it will cause hyperfunctioning. Can you imagine the difficulty? Now in immunology, in a given set of person, there is a flip-flop type of thing. Means at one point of time his body, the patient's body is producing stimulating type of antibody, at one point of time is producing inhibited. And I got one case and I have reported it. And this is another part, I am not going to tell this thing. So flip-flop of blocking and stimulating type is there and that particular mother of that baby child was having this problem for a long time. At one time it is not matching and doctors will not be satisfied, patient will not be satisfied, that laboratory is giving wrong report, this laboratory is giving right report. It is not like that. At one point of time blocking antibody is there, at one point of time stimulating antibody is there. So there is a oscillation between the hypothyroidism and hyperthyroidism and it is very difficult to adjust the dose. So that part, whether iodine is being taken up or not, as I told you, this is done by the nuclear medicine department and that is done by radioactive iodine uptake. And if you will see that this type of image will come and from that image you will be able to see that whether the thyroid gland is functioning or whether the thyroid gland is not functioning. So apart from this radioiodine scan, USG is done, CT scan is done, fine needle aspiration cytology is done, biopsy can also be taken, but these are done to know what type of disease the patient is suffering from. Now even if somebody is having a tumor on the thyroid gland, but if it produces normal amount of T3, T4, FT3, FT4, so there is no functional disturbances. He might be having a tumor, he might be having that patient might be having a cyst also, but there is no functional deficiency. But that cyst or tumor has to be removed. Or if the patient is having a little bit of, say suppose one part of cancer is also there, that needs to be treated. Otherwise the entire gland will be involved and the effect of cancer will be there. But that may or may not cause any functional disturbances. Functional disturbance will be assessed by T3, T4, TSH and FT3 and FT4. These are done for disease diagnosis purposes. So, oxidation of iodine. So, iodide is oxidized by thyroperoxidase enzyme to iodine. Now, if there is an antibody, anti-TPO antibody which is commonly done and you will be prescribing also, so that thyroid peroxidase enzyme will not act. So, therefore, there will be hypothyroidism, because after taking up iodine it is not able to oxidize. Once the iodine is oxidized into elemental iodine into the thyroid gland, just like your this bilirubin or just like glucose, it will not allow the iodine to come out from the thyrocytes. So, anti-TPO antibody, remember one thing I am telling you, if you find a case of hyperthyroidism, please inquire confidentially about the psychological status of that person. Usually there is a history of severe mental stress and that precipitated a disease, and all my cases have revealed this thing in person. So, there is a genetic element to have that disease, but a severe psychological stress has precipitated that disease. So, basically brain, gene, immunology, thyroid gland was involved in that entire process. So, that may be true for many auto and immune diseases. Most of the autoimmune diseases are fluctuating in nature and their basis is basically psychology. Psychiatric problem, psychiatric crisis, which we often forget to ask in a busy clinic. Now you have to counsel, and that lady was counseled, honestly speaking. At our home, I went to her house, I knew what was the actual precipitating factor of having that disease, because she developed the disease after her marriage. So, iodination is there. That molecule I told you, that MIT, that is monoiodotyrosine, that is one iodine molecule is here, and this is diiodotyrosine because two molecules are there. So, these two molecules, when they combine, they form T4. It is having 4 iodine, and when one molecule of MIT and one molecule of DIT is produced, that is called triiodothyroidism. Now, since iodine is a very scarce element, so body evolved a mechanism by which T4 is converted into T3, so that if you use 3 molecules of T4, so there are 12 atoms, from out of 12 atoms, 3 molecules you will get 4 T3 molecules, and T3 is 10 times metabolically more potent, and that's why T3 is metabolically more active, because of that reason, iodine being a scarce element geochemically. So, that coupling is there. So, this I have told you. These thyroid glands are stored, and the thyroid glands, several weeks of supply of thyroid gland is there. So, just a patient has stopped taking a drug. Why did you stop the reagent? It will not result any deficiency or any disorder, because it is having a good amount of storage. So, even if somebody stops taking thyroid replacement hormone for 1 month, it will not cause that much deficiency, because from the storage site it will come out. Then there is utilization, finally there is a hydrolysis, and then it will come out from the blood. So, release, after release, all these things will not be utilized. So, again this MIT and DITs are recycled, and it is taken up by the thyroid gland, and as I told you, just like bilirubin, T3, T4 as such is not soluble. So, they are transported using this, you note down here, 80% of the T4 and 60% of the T3 is bound to thyroxine binding globulin. At least one part you must remember, that the transport protein is thyroxine binding globulin, and rest is albumin and thyroxine binding pre-albumin, or it is called transthyretin. This part you write down, this red letter, transport of thyroid hormones. This is important because if there is a level, TBG level is high due to any cause, it will increase the total T3 level. Do you understand? If there is any disease which decreases T3, TBG production, it will decrease the total T4. Total T4 level will be altered with the alteration of TBG. If the amount of TBG is high, as you will see in a short while, in some conditions, mainly pregnancy and taking oral contraceptive tablet, TBG levels are high. So there will be total T4 elevation or total T3 elevation, not the free form. Similarly, in nephrotic syndrome, TBG level is lowered. So there will be decreased T3 and T4, total T3 and but FT3 and FT4 will be normal. So functionally, there will not be hyperthyroidism or hypothyroidism. Then, as usual, it is also catabolized and conjugated again with glucuronic acid, universal agent, and it is excreted through the bile. Excretory mechanism are basically through 4 routes. One is basically stool, that is not a metabolic but the digestion. One is urine, second one is bile, third one is through sweat, and fourth one is through respiration. So this is a summary. I am not going into the detail. You read it from the book. I will not be able to cover. Regina, takao edike takao. Anti-thyroid drugs you will be giving those patients who will be suffering from hyperfunctioning of the gland. You need to give drugs to control its production. These are called anti-thyroid drugs, and carbimazole is one of them. What they do? They inhibit the TPO. Write down this, only the upper part. Anti-thyroid drugs, what is the mechanism of action? Only the top part you write down. Anti-thyroid drugs are two basically used. Carbimazole is maximally used. So what they do? Basically they inhibit the function of the TPO, reducing oxidation and organification of iodine. So therefore, less iodine will be, less hormone will be produced. So it will bring the higher level to a normal level. Anti-thyroid drug. And the mother of the daughter, that child, was treated with anti-thyroid drugs. In contrast, her daughter was treated with thyroxine because she was having hypothyroid. Her mother was a hyperthyroid patient. So as you can understand, in one spectrum of the disease, you are having a hyperthyroid, at another end, you are having the hypothyroid. Because stimulating type, blocking type of antibody, and this is only a crude part, less than a bird's eye tip of the iceberg, what I have told. It's not that easy. This you note down. This I have already explained. So T3 bound form is 99.7 and free form is 0.3. This will be asked in the question. T4 percentage bounding. So T4 is a pro-hormone. Why it is called pre-form? Because T3 is produced from that, and that is a metabolically active form. এই তিনটে পয়েন্ট লিখে নাও, যে তিনটে পয়েন্ট শুধুমাত্র এই মেজেন্টাতে লাগানো, যে টোটাল সেরাম কনসেন্ট্রেশন দেখো এটা খুব কম আছে। দিস ইজ T3 is in microgram per deciliter 0.14. This is 8 milligram. A serum half life T4 এর আছে 7 days, T3 is 2 days. A fractions directly from the thyroid gland, and I told you it is 100%, and this is from 80%. And metabolic active potency, T3 is 3 times more potent than T4. These 4 points you must remember. Rest forget, you will remember later. Regulation of secretion. This is most important to understand the functional part. So FT3 and FT4 are the main things which regulate its secretion. So what happens? This part I think you learned about during your class 12 class. So there is a hypothalamus which is on the top. And then thyroid. Normally what happens from hypothalamus, TRH, thyroid releasing receptor releasing hormone, TSH releasing hormone is produced. That stimulates pituitary to release TSH. That TSH acts on the thyroid gland to produce T4 and T3. Okay. Now one part, as I told you, this is FT3 and FT4. Now by chance if the production is less, what it does, it stimulates the pituitary. Basically it stimulates the hypothalamus to produce more amount of TSH. So if this level is low, this level will go high up. This TRH will be produced in high amount. So this will be in high amount. This will in turn result in high amount of TSH. In an attempt to compensate, try to understand, in an attempt to concept the disease doesn't occur overnight. Just like you cut the hand, there is a cutting and there is a bleeding. The disease doesn't occur overnight, and just like an acute phase like this, it develops over a period of time. You see the regulatory step, and then when this regulatory compensatory mechanism will fail, then only the disease will occur. So what happens when due to thyroid gland damage due to any cause, T3 production will be less than normal. It will stimulate the hypothalamus, it will stimulate the pituitary, more TSH will be produced. So in the initial stage, FT3 level and FT4 level will be within the normal range also. TSH level will be high, T4 level will be high. Now if that condition persists, usually it is a progressive disease, occurs over years. That's why the body gets adjusted and you will not get the classical symptoms until and unless the disease is quite advanced. These type of cases you will not be able to see. Rather you will see very early cases. So when this level is lowered, actually FT3-4 and FT4, when it is within the normal range, but TSH level is high, that means this is an early case of hypothyroidism, that is called subclinical hypothyroidism. Now when the FT3 and FT4, particularly FT4 is low, FT3 is lowered at a later stage, FT4 is low, TSH is high, that means it is a case of clinical hypothyroidism. It has progressed. The less the TSH at FT4, at one point of time when the disease is advanced, FT3 will also be lowered. Now if you find an FT3 and FT4 is lowered, TSH level will be very high. The disease will progress. The more the lowering of TSH, more the production of TSH. And I have seen the highest level, normal TSH level is 4, and I have seen in a child of 4 years old 1700, and that I have told in the national conference. 1700, and with a single dose of only 50 microgram of thyroxine, the level was brought down to 4 only in 3 weeks time. So once you give a replacement therapy, so that will basically inhibit this path and this level will be lowered down. Okay? Just in contrast, reverse, if due to hyperfunctioning of the gland, if the gland starts hyperfunctioning, if there is a stimulatory antibody which is allowing the gland to function more, much more than what is required, so what will happen? T3, T4 will be higher, it will be in high amount, it will be in high amount. The more the disturbance, more the higher, more the level will be increased. Accordingly, FT4 will be also be increased and FT3 will also be increased at one point of time. And this will again now, in here it was increasing, it will inhibit. It will inhibit that do not produce, it will give an instruction to the hypothalamus, don't release TRH. So, hypothalamus will release less amount of TSH, less amount of TRH, less amount of TSH. The more the amount of T4, more the decrease of TRH, more the decrease of TSH. So, in a case of early case of hyperthyroidism, you will get this FT3, T4 higher. T3, T4 may be normal, but TSH level will be low. Now, if the TSH level is very low, look at the FT4 and T3 level. T3 level will also be low, higher. T4 level will be also be higher. FT4 will be also be higher. FT3 will also be higher. Because of the reserve capacity, as I told you, 0.3 and 3%. Remember that thing. So, body tries to maintain an equilibrium. When that equilibrium is exhausted, the compensatory capacity, then only this disease will occur. Now, I think you will be able to interpret the report. Hopefully, you just think of it. So, that is the actually pictorially I have described here. If less T3 and T4, then increase TRH and TSH. If more T3 and T4, in other words, more T3 or FT3 and FT4 basically, because these are the main regulators. So, earlier this T3, T4 was done. This is the reason why you will do FT3 and FT4. And it take a snapshot of a given point of time. If a patient, I am telling you, if a patient opts for one investigation, go for TSH. If TSH is high, that means primary hypothyroidism. If TSH is low, that means it is hyperthyroidism. Okay, if one test is allowed. If you allow two tests, go for FT4 and TSH. You will be able to diagnose hypothyroidism and hyperthyroidism. Now, if three tests are required, then go for FT3 and FT4 and TSH. If 5 tests are allowed, then you go for all 5. Take a snapshot of given point of time. All the persons, most of the persons are not that poor today. So, if you suspect any disease, somehow convince the patient, get a report of FT3, FT4, T3, T4 and TSH at a time, so that you get a full picture. Now, if there is a normal patient, you will be able to know. If the patient is diseased, you will get a baseline value. Because today, if you have done T3, T4, TSH, and next time you will see that you give FT3, FT4, after 15 days you will give the blood, or 7 days, the body at this today's blood level may not be corresponding what is the level of after 15 days. So, basic objective is to somehow convince the patient, and patient will definitely agree. So, earlier what happened, when we are students, we used to tell if the gland, suppose this is the gland which is getting primarily involved. So, this is called primary hypothyroidism. The disease may occur here, the disease may occur here, disease may occur here, disease may occur here. If the disease is primarily involving the thyroid gland, it is called primary hypothyroidism or primary hypothyroidism. If the disease is at the pituitary level, that is secondary hypothyroidism or secondary hypothyroidism. If it is at the pituitary level, that is called tertiary hypothyroidism or tertiary hyperthyroidism. Now, these two terminology of secondary and tertiary has been removed from 2000. So what they say, a primary and central. Central means it is within the brain. Pituitary is in the brain and third gland is in the brain. দেখো তো অ্যালার্মটা বোধহয় কোথায় বাজছে কারো। So basically there are two criteria. One is you have to diagnose whether it is primary hypothyroidism or primary hypothyroidism or central hypothyroidism or hypothyroidism. এইটা লিখে নাও তো একটুখানি, এটা মানে এখনো পর্যন্ত ডাক্তার গতবার আমাকে কনফারেন্সে এটা ঠিক করতে হলো। আমাদের এমবি কনফারেন্স যেটা ছিল, NRS এর অ্যাসোসিয়েট প্রফেসর, হি রিপ্রেজেন্টেড ইট রংলি। Write down this thing and remember, when the HPT axis is intact and the system is in equilibrium, there is an inverse log linear relationship between the concentration of TSH and FT4. As I told you that it will increase and it will decrease, it is not linear. It is not linear, it is in log linear fashion relationship, and that is not in linear, inverse log linear. What is inverse log linear? If you have taken a graph paper, you have seen, if you see 0, 10, 20, 30, 40, 60, you will get 10, 20, 40, that is linear graph paper. Here it is in the linear sequence, it is in the logarithmic sequence, that is 10 to the power 1, 10 to the power 2, 10 to the power 3, 10 to the power 4, just like that. So why is this? Why is this? See, if you just concentrate here, if you look at any parameter in biochemistry, there is a range between the lower and upper, and the difference is usually 2 times, not more than 2 times between the lower and upper limit. But only in case of TSH, the range between the lower and upper is 24 times, and it is the highest in the range of any known biochemical parameters measured. So since the level is very high, the range, so how will you represent it? It is not linear. So a small fraction of FT4 will cause a significant change in the TSH level. So this is the reason why FT4 is in the linear fashion here in the x-axis, and TSH is in the y-axis, it is in the logarithmic form. That's why it is called inverse log linear fashion. This is not written in your book. This I have to search it from Metabolic Clinics of North America in the year 2002. I had to search it out, that I am not getting an answer to this thing. So that was the reason why this is not, doesn't matter. Some clinically relevant information. So if now I am going hurriedly, I will take 10 minutes time. So if the function is normal, that is called euthyroidism. If it is low, then this is called hypothyroidism. If it is high, then this is hyperthyroidism. And remember, clinically, in an OPD setup, you will see the patient, whatever written in the textbook, you will not find all the cases I have tried. I have not found. I am telling you, really, I have done that PhD topic on that. I tried to find out what the clinicians expect, that these are not found, because the disease that requires an advanced stage of the disease, particularly in the very remote area where healthcare facilities are not available, you will get this type of cases. So biochemical, whatever, even if you diagnose hypo, biochemical test is mandatory. So that you have to confirm it, and because that test is required, because you have to monitor. Biochemical test, without biochemical test, you cannot disease that patient empirically. So as I told you, the goiter means any enlargement is called goiter. So goiter can be iodine deficient. Remember, today we are not seeing any case of iodine deficient goiter. Whatever we are seeing are iodine sufficient goiter. So don't try to give iodine. And the cause of the iodine sufficient goiter is autoimmune thyroiditis. It's an autoimmune disease. which destroys the gland or which overactivates. It's not deficient. Unnecessarily will cause problem by giving iodine therapy, which our clinicians used to give before to the in the middle of till the middle of 9th, and I had to stop it. Don't do it. So these type of cases you may get in Santiniketan, because this is a rural medical college. Many ignorant patients will come, but in all are health conscious. You will not get this type of cases. দেখতে পাচ্ছ এইরকম স্টেজে পেয়ে যাবে patient will come in this stage that my patient came, but these type of cases I am telling you, only those who are not health conscious, even they are afraid of getting a surgery. Everybody is afraid of surgery. So if I go to the, they will cut it. Wait. Don't get restless. This is one important point. I had a free seat. Maybe I will not be taking any more class. So this is not found. There are many diseases. I am not concerned about those diseases. I am concerned about hyper congenital hypothyroidism. Remember, it's a mandatory practice to identify hypothyroidism in a baby, because if you don't treat, that will cause permanent neurological damage. And in our family setup, now we are having our 1 or 2 child norm. You will have a mentally retarded child, and there will be no cure for it. Neither the child will die. So it's a lifelong burden. So detect hypothyroidism while it is still the baby stage, particularly soon after delivery. So these are the fates of the actually carrying child. This picture you will be seeing in the book, but this picture you will not got in the OPD. So therapy is very simple. I am not on hyperthyroidism. Hypothyroidism is very difficult to diagnose clinically. In contrast, hyperthyroidism you will be able to diagnose, because through the by just looking. So if you want to talk, I'll stop. I told you earlier, if you don't want to listen, please go out. Don't make any noise. At least one student is there, I'll speak for him. I am telling you, hyperthyroidism is easy to diagnose. By looking at the patient, you will be able to diagnose. By looking at the eyes only. Hypothyroidism is very difficult to diagnose. Hyperthyroidism is easy to diagnose. So there is a drug, thyroid function test coming. This I have already told. Normally, normal functioning means it is euthyroidism test. Less, it is hypothyroidism. It will take another 5-10 minutes maximum. So how will you collect the blood? Again, important thing I told you, because you are primarily responsible. So blood will be given in the plain tube or gel tube or a vacuum. Don't allow other anticoagulants to be added, because we want serum. That must be ensured. Otherwise, we give a wrong report. Single test, as I told you, if option is there, go for TSH. Look at the level of TSH. If 2 tests, FT4 and FT3, and 3 tests, triple test, FT3, FT4, TSH, as I told you, complete state of thyroid function test, take a snapshot, all 5 tests. TSH, the TBG level, I told you, if the level is high, then total T4 will be high, but FT3, FT4 will be normal. Similarly, if the level is low, then you will have a low T3, T4. So now you come to the interpretation. If FT4 and FT3, FT4 TSH is normal, while total T3 and T4 is high, take history, usually a pregnant lady, because TBG level is high, or she is not pregnant lady but married lady, inquire about oral contraceptive. That has increased. Similarly, if the TSH is low, check the albumin level. There are many drugs which displaces also T3, T4, TSH from its binding site. Anti-TPO antibody in all cases of hypothyroidism, whatever you will get an anti-TPO antibody done, whether immunological factors is responsible for that or not. Usually you will get an antibody, anti-TPO antibody, because this thyroxine peroxidase is not able to function because of that thing. Serum thyroglobulin is done to monitor the patients suffering from thyroid cancer, not done normally. Importance of this test, whatever is your clinical expertise, you have to do a biochemical test to confirm, just like LFT, whether it is a hypothyroidism or whether it is a hyperthyroidism. Just like sugar, you have suspected this is a case of diabetes, but you have to estimate the blood sugar, whether it is high or normal. Then monitoring at different types of intervals that I have shown in the mother and the child daughter case. And both are normal now. Methods of estimation, what we did at Durgapur was radioimmunasy. Radioimmunasy, that is a gold standard method. ELISA is done in some laboratory. Chemiluminescence analyzers are available. In 1998, I wanted to procure this machine at our hospital, but the funds were not given to me, because we are having the most reference method for radioimmunasy from Bhabha, and this still continues to be the reference method, but unfortunately that method is not used. Chemiluminescence is the most method. So clear, you will see the result of T3, T4, TSH. Method is written CLIA, clear. That means chemiluminescence. Now, while interpreting, pay attention for just 2 to 3 minutes more. First, look at the level of TSH. If it is normal, whether it is normal, whether it is low or high. First look, just like your jaundice case I told you yesterday. Then FT4. Look at the level, whether it is normal, it is high, or then look at the FT3 level. First look at the level of TSH. What is the level of TSH? Euthyroidism, all cases will be normal. As I told you in the picture, that in early case, that is subclinical case, you will get a normal FT3, FT4, TSH is normal, but TSH will be high. Now, in the later stages, first FT3, T4 will be low, then total T3, T4 will be low, and TSH will be very high. In contrast, hyperthyroidism, just the reverse. এই টাইপের কোশ্চেন আসবে পরীক্ষায়, একদম টিপিক্যাল কোশ্চেন আসবে। এইবার বলো, একজনকে উঠে দাঁড়ায় একজন বলবে 5টা কেস আছে, চটপট করে বলে দেবে, এটা বলো ডায়াগনোসিস বলো। দাদা ছটপট করে এইটা দেবে না, আমি এগুলো একদম শান্তিনিকেতন ল্যাবরেটরি থেকে তুলেছি। চট করে বলো, কেউ একজন বলো বলো। হ্যাঁ, হাইপারথাইরয়েডিজম লেটেস্ট একদম বলে ঠিকঠাকই বলেছে, মোটামুটি হাইপারথাইরয়েডিজম আছে, হাইপারথাইরয়েডিজম আছে পাক্কা। আর্লি স্টেজে আছে একটুখানি, কেন কি একটু মার্জিনালি ছেড়েছে লেভেলটা, দেখতে পেয়েছো? এটা একটুখানি বেড়েছে, এটা একটুখানি বেড়েছে। হাইপারথাইরয়েডিজম আর্লি স্টেজে আছে, মানে খুব অ্যাডভান্স হয়নি ডিজিজটা, বাট ইট ইজ এ হোয়াট কেস। ইয়েস, সিট ডাউন, ঠিকঠাক বলে দিয়েছে হাইপারথাইরয়েডিজম। এইটা বলো। বলো বলো, তো একদম ঠিক বলেছে, একদম কারেক্টলি। এই হচ্ছে সামনে বেঞ্চে বসার সুবিধা, শুনছে বসে বসে, আমি দেখতে পাচ্ছি তখন থেকে। হাইপার হাইপার বলো, এই বলো তো ঠিক করে, চেষ্টা করো বলে দেবে। এটা আর্লি হাইপারথাইরয়েডিজম। কি বললাম বলো, প্রথমে শুনলে না ভালো করে। লুক এট দ্য লেভেল অফ টিএসএইচ। টিএসএইচটা নর্মাল আছে না নাই দেখো আগে। টিএসএইচ নর্মাল আছে, তাহলে হাইপার হবে না, হাইপার হবে না, ব্যাস সিম্পল। হ্যাঁ, এই জন্যই তো maximum the doctor cannot interpret and they erroneously diagnose this case, and many persons are doing like the only. and they create confusions. They charge the patient, go to the laboratory, they are giving wrong report. বলো একজন কেউ ভলান্টিয়ার করো, একটু ডাক্তারি করতে হবে বাবা, এতক্ষণ ধরে বললাম, এবার না হলে এখন আমার নিজের খারাপ লাগবে। বলো ভুল বলো, এত বলেছো ঠিকঠাক বলে, দুটা ভুল বলো, আমি বলে দিচ্ছি, কারেকশন করে দিচ্ছি। কি পাচ্ছ দেখো, ফাইন্ডিংটার মধ্যে কি পাচ্ছ বলো তো? কিছু অ্যাবনর্মালিটি পাওয়া যাচ্ছে? কিছু অ্যাবনর্মাল, কোনো একটা অ্যাবনর্মালিটি আছে? T4টা হাই আছে, দেখো ভালো করে তাকিয়ে দেখো, T3টা নর্মাল আছে, T4টা হাই আছে। এইবার পেশেন্টটার এজের দিকে দেখো, এটা 26 ইয়ার্স এজ আছে। 26 ইয়ার্স এজে কি হতে পারে? পেশেন্টটা প্রেগনেন্ট হতে পারে, পেশেন্টের ম্যারিড লেডি হয়, ওরাল কন্ট্রাসেপটিভ ট্যাবলেট খেতে পারে। তাহলে প্রেগনেন্সি হলে ওরাল কন্ট্রাসেপটিভ ট্যাবলেট খেলেই টোটাল T40 বেড়ে যাবে। ঠিক আছে, যখনই এই কেসটি পাবে ফার্স্ট ওকে জিজ্ঞেস করবো কি আছে কন্ডিশনটা। ঠিক আছে, প্রেগনেন্ট হলে তো দেখতেই পেয়ে যাবে মোটামুটি, না পড়লে আর্লি প্রেগনেন্সি হলে দেখতে পাবে না, জিজ্ঞেস করে নেবে। আর তাহলে ওরাল কন্ট্রাসেপটিভ হিস্ট্রি আছে কিনা, ইউজুয়ালি উইল গেট ইট। বোঝা গেল ব্যাপারটা? পরটা দেখো তো, এইটা বলো। হাইপার হাইপার বলেছে, হাইপার বলেছে, দেখো বলেছে, এই বলো কি আছে? আমি মেয়েদের ইচ্ছা করে বলছি, কেন গে মেয়েদের শিখতে হবে বাবা, বলো। It's a classical case of gross hypothyroidism. You look at the level of TSH, it is very high. Look at the level of T4, look at the level of T3. This is quite low. Total T4 has gone down, total T3 has gone down, TSH is up. It's a case of gross hypothyroidism. Gross, not early. Early হতে পারতো, এতটা TSH বাড়তো না যদি আর্লি হতো। আর্লি হলে বড় জোর TSHটা 15, 20, 10 এর রেঞ্জে থাকতো, 25 থাকতো। ওই T4 TSHটা T3 T4টা নর্মাল লেভেলে থাকতো, তাহলে সেটা আর্লি কেস হতো। বোঝা গেল ব্যাপারটা? এটা যেটা পড়াটা দাও, এটা বলো, এই এটা বলো, এই ছেলেটাকে জিজ্ঞেস করি, এই তুই কথা বলি, বল বল কি আছে, কি কেস? হাইপো, এ বলেছে হাইপো। এই চারদিকে মুখ ঘোরালে এই করবি বসে বসে। এই আর কে বল, এই বল, এবার নর্মাল। The most talented person sits usually in the back benches, I know. All the students who are sitting on the back benches, it is APJ Abdul Kalam's statement. The brilliant students of the nation usually sits at the back benches. And I consider all of you are the brilliant students of the nation. It's not my statement. So please come up. Hey, ball, দেখি। ও তো বলে দিল হাইপো, এ বলছে নর্মাল। এ নর্মাল বলেছে, বল এটা কি বল? একদম নর্মাল, সব করে পারবে না, নর্মাল আছে। দেখলে এ না শোনার ফল দেখতে পাচ্ছিস? ক্লাসে এতটুকু শুনেছি না তো, টাকা লেভেলটা পাস নর্মাল লেভেলটা লেখা রয়েছে, কোথায় আপনার ডিপেন্ডে? পড়াটা দেখো, বলো বস, অন্য জমি দিচ্ছে, বল বল বলো কেন টাকা এইখানে বলতে হবে তোকে সবাইকে, আজকে করাবো এখানে। থার্ড রিপোর্ট একটা ভুল বলা যাবে না, একটা কেসও ভুল বলা যাবে, ডায়াগনোসিস করা যাবে না। কালকে বকেছি আমি, আজকেও বকবো। শান্তিনিকেতন মেডিকেল কলেজ স্টুডেন্ট হয়ে যে রিপোর্ট ইন্টারপ্রেট না করতে পারে, আমার লাগবে। বল এটা কি কেস আছে? একদম পাক্কা ঠিকঠাক বলে দিয়েছে। বলো কি বলছো? হ্যাঁ, আর্লি হাইপোথাইরয়েডিজম, একদম সাবক্লিনিক্যাল। এই কেসটা ইউজুয়ালি একটা FT3 করে নেবেই, একদম দেখে নেবে FT3 লেভেলটা কি আছে, লো আছে না হাই আছে। লো থাকলে মোটামুটি ডিজিজ একটু অ্যাডভান্সই হচ্ছে। ওকে, যেহেতু T3 T4 TSH আমাদের শান্তিনিকেতন মেডিকেল ল্যাবরেটরিতে করা হয়, সেই জন্যই আমি এই রিপোর্টটা দেখাচ্ছি। আমি ডেলিভারলি FT3 FT দেখাচ্ছি না। বোঝা গেল ব্যাপারটা? এই হসপিটালে তোমরা ইন্টার্নশিপ করবে। পরেরটা দেখাতে জন্য দেখ, ফুল স্ন্যাপশট 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 স্ন্যাপশট। একে ধরেছি, এই বল বল মোস্ট ব্রিলিয়ান্ট স্টুডেন্ট অফ দ্য ক্লাস সিটিং ইন দ্য ব্যাক বেঞ্চ। এই বল ওর 3 জন মিলে ওর, এই ওঠো বল। আস্তে আস্তে মামি করা, কেউ বলো না, বল চুপ 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 করে থাকো। নর্মাল নর্মাল বলেছে, বস অনেক হয়েছে। নর্মাল বসে যা, গুরুদেব তোকে প্রণাম করবে এবার আমি। বল, তোকে প্রণাম করবে এবার আমার, তোদের দুজনাকে। এত কথা কি করছিলে ক্লাসে? পড়ে বক বক করলাম। এতক্ষণ ধরে এই করলি বসে বসে। নর্মাল বললি তোকে, নর্মাল বললি এই কেসটাকে দেখতে পাচ্ছি না চোখের সামনে অ্যাবনর্মালিটি। কি বললাম এতক্ষণ ধরে? লুক এট দ্য লেভেল অফ TSH। একটা শুনবি না, কথাবার্তা শুনবি না, একটা রিপোর্ট দেখা যায় বলতে পারবি না, ভুলভাল চিকিৎসা করবি। TSH লেভেল লো আছে, FT4 লেভেল দেখ হাই আছে, FT3 লেভেল দেখ একদম আপার নর্মাল রেঞ্জে চলে গেছে, ওটা একদম চলে গেছে কাছাকাছি। হ্যাঁ কারণ ওই দেখো T4 টোটাল রিপোর্টে দেখেছো, আপনি টাকা টাকা ভালো করে টোটাল রিপোর্টে দেখো নর্মাল রেঞ্জে আছে, টোটাল T3টা দেখো নর্মাল রেঞ্জে আছে, FT4টা দেখো ওই দেখো বেড়ে গেছে, দেখেছো? আর FT3টা এখনো পর্যন্ত বাড়েনি, এরপরে আর একটু অ্যাডভান্স হলেই বাড়বে, আর TSHটা আরো বাড়িং হয়ে যাবে। সামওয়ার বিটুইন সাবক্লিনিক্যাল অ্যান্ড ক্লিনিক্যাল, একটু মাঝামাঝি জায়গাতে আছে ডিজিজটা। কত ছবি তুলবে, যা ল্যাবরেটরিতে গিয়ে অজস্র ডাটা পাবে। চলো আর আছে, দেখে দেখো কেস দেখো তো। হ্যাঁ এইটা বলো, এইটা তুমি বলো তো। এই তুমি বলো, তুমি বলো। ঠিক তো? শিওর? কোথায় গেল? এই এটা কি হয়েছে বল। হ্যাঁ বল কি আছে? বাঁচা গেছে নর্মাল। চল ঠিক আছে, ছেড়ে দেয় ছেড়ে দেয়। আর আছে নাকি দেখা তো? আর নাই, আর নাই। আচ্ছা আগেটা দেখ, আগেটা দেখ, আগেটা দেখা, আগেটা দেখা, আগেটা দেখা, আগেরটা 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 আর তার আগেরটা দেখো, এটা দেখো, এটা দেখো। আবার চেষ্টা করো, চেষ্টা করো, চেষ্টা করো, চেষ্টা করো, চেষ্টা করো। ভুল বলো, ভুল বলো, কোনো অসুবিধা নেই। চেষ্টা কর, চেষ্টা কর, চেষ্টা কর, চেষ্টা কর, চেষ্টা কর। ব্যাক বেঞ্চে কে আছে? এই বলো। এই তুই বলো। ঠিক আছে, বসে বলো। কে বলবে, কে বলবে এদিকে? এই তুই বল। হ্যাঁ বাঁচা গেছে, চলো হয়েছে। চলো পয়েন্টটা দেখো, পয়েন্টটা দেখো, পয়েন্টটা দাও। বাস, লাস্ট কেস, লাস্ট কেস, লাস্ট কেস। ওই কোনা লাস্ট কেস নর্মাল হয়েছে। এবারে মোটামুটি আইডিয়া হয়েছে, বুঝতে পারবে, করতে পারবে। বাস চলো।